So, as I say, keyhole surgery pioneers. My name is Roger Kneebone. I'm the Gresham College visiting professor in medical education, and I'm Professor of Surgical Education and Engagement Science at Imperial College London. And at Imperial, I lead two centres. One of them is a centre for engagement and simulation science, and the other is a collaborative centre between the Royal College of Music and Imperial College, which I lead jointly with my friend and colleague Aaron Williamson, who's in the audience today. And over the next hour or so, I'm going to do two things. The first is to spend perhaps half an hour setting the scene about keyhole surgery and the convulsive changes that that's brought to the surgical landscape over the last 20 or 30 years. And then after that, I'm going to invite to join me on the platform two of those keyhole surgery pioneers for a conversation which will take the rest of the lecture. So if you have your gallbladder removed, if you've had your gallbladder removed or you're about to, these days, almost certainly it will be done like this. It will be done by keyhole surgery. So for those of you who are not familiar with this approach, the surgical team will put a tiny, tiny camera through a small incision, probably just underneath your tummy button, and then maybe a couple of other tiny punctures in your abdominal wall, and they'll feed instruments into your abdominal cavity, and they'll see what they're doing through a magnified, brightly lit image that we can see over there on the left of the picture. And so the surgical team are not looking directly at your organs, they're looking indirectly through optical instruments. And then they will carry out the procedure, probably in no more than 20 or 30 minutes, using rigid instruments. It's a rather peculiar environment in a way. Often the light is strange to allow people to get the best possible view of the screens. And I'm just going to give you a glimpse of the kind of thing that you might see if you were in the operating theatre. So we've got an operating team here. We've got the surgeon there. She's looking at a screen, her assistant at another screen. The scrub nurse over there, he's providing the instruments. And over there on the left, you can see the anaesthetist. And it would look something like this. But although this kind of surgery seems completely routine now, it hasn't always been like that. And so in this lecture, I'm going to track the process by which something arrives on the landscape, and it's entirely new. Nobody's seen anything like it before. But then surprisingly quickly, it becomes normal. It just becomes part of how things are. And then surprisingly quickly after that, very often, it becomes old because it's supplanted, superseded by what comes after it. And so in the course of this talk, I'm going to look at that trajectory, that process by which new approaches, new technologies, new ways of doing surgery go through this cycle. So a lot has happened in the course of my surgical career. So in the 40 years or so since I qualified in 1977, there have been all kinds of convulsive changes. Of course there have. And in the middle, in the 1980s particularly, there was the beginnings of a fascinating time of enormous technological change and enormous social change. And I'm going to explore how those two elements interacted. So let me take you back to when I was training as a surgeon. Here I am over there on the right in my earlier days in the 1980s, carrying out an operation, in this case a trauma surgery operation in Southern Africa, where I was at that time. And you can see that I'm looking down directly into the abdominal cavity of the patient I'm operating on. Patient's under general anaesthetic. I've made an incision and I can see directly what it is that I'm going to do. And this is a form of surgery that was universal at the time. And so now I'm going to just show you a brief glimpse of a reenactment. My colleagues and I did a simulation of that kind of operation, the sort of thing you'd have seen in any hospital in the 1980s. And you can see that round about the surgical team, we've got the surgeon there. Opposite him is the scrub nurse, almost always a woman at that time in the background, the anaesthetist, more often than not a man, though by no means always. And around about, we've got members of the public who are coming to see what that sort of operation was like.
The students in the operating room, right angle.
And so you can see the kind of thing that was happening, and it would be like that for the operation, the very commonly performed operation of removing the gallbladder, in technical terminology, cholecystectomy. So a while ago, I started thinking about what was going on at that time. What kind of surgery were we looking at? And I'm going to show you a brief clip of an educational video that lasted half an hour, but I'm just going to show you a few seconds, of this operation, produced as an educational tool for medical students by Professor Harold Ellis, who at the time was the Professor of Surgery at the Westminster Hospital. He's now retired from clinical practice, very active as an anatomist at Guy's, but we'll see him now explaining the beginnings of this operation.
I'm going to demonstrate in this presentation a cholecystectomy on a middle-aged lady with multiple gallstones. The peritoneum opened over the duct system, carefully dissected away, and this is helped by a Leahy swab, a small swab held in an artery forceps. Push away the tissues. Here we are.
So there's just a glimpse of the beginning of this operation. Now, at the time, as I say, this was the absolutely standard way of doing this procedure, the only way, really. That's how I learned to do it. That's how all the surgeons learned to do it. And when I was learning to do it, it seemed to me that it had always been like that gallbladders had always been removed in that way. And in a sense, for a very long time, they had. The film I've just shown you was filmed in the mid-1980s. And here's one from the Wellcome Collection's archive of the same operation being carried out 40 years earlier in the 1920s by Mortimer Wolfe. And when we see what Mortimer Wolfe is doing, it's almost indistinguishable from the operation that Harold Ellis was doing 40 years later. We can see very similar stages of the operation, very similar procedures that they're doing. And this was based on a way of looking at the body that involved making a hole in somebody and seeing with your own eyes what was there. And in order to get a sense not only of the textbook descriptions of those operations, but what people were actually doing at the time, I wanted a while ago to start to think about ways of documenting what was going on, to get at what people were actually doing, rather than those descriptions of what they were doing that really only make sense to insiders, to people who already know what the language means. So when I started doing this a few years ago, first of all, I got in touch with Professor Ellis, much older now than he was when you first saw him there. And he gave me the perspective of what it was as a surgeon, but I wanted to expand that and get some other perspectives too. So I started talking, first of all, to Sir Barry Jackson, who not long before that had been the president of the Royal College of Surgeons of England, an immensely experienced surgeon like Harold Ellis, who'd done hundreds, if not thousands, of these operations. And I asked him to explain to me what he did, and to tell me, to take me back to that time when he would go into the operating theatre and do this operation that was so deeply ingrained he could do it more or less in his sleep. And here's what he said.
Now, I would be... just hang on. I stood on the other side. I stood on the patient's left.
So that's
the patient's head there. I would be standing this side and make the incision. Yes, that's right. Subcos.
So I think we get the sense here that he's finding it difficult actually to visualize what he did. It's become so automatic that he has to think through which side of the patient he was standing on, whereabouts in the operating theatre he was, all those things that are absolutely second nature, he wasn't used to putting into words. So when I asked him, he found it quite difficult to say because he had to cast his memory back. In fact, he ended up drawing little diagrams of where he was standing and where the patient was lying, that sort of thing. And so I started to realize that there was a whole body of sort of unarticulated knowledge that experts had, but couldn't always bring out into view. And when they were explaining to people who were not so expert, it became a problem. I was also very fortunate in getting in touch with a number of other members, first of all, of Harold Ellis's team. This is Professor Stanley Feldman, who died several years ago, very eminent anaesthetist, professor of anaesthetics at the Westminster Hospital, and he and Professor Ellis had worked together for many, many years. And this is Mary Neeland, their theatre sister, senior theatre sister, who again worked as part of their team together for a very long time. And I worked with them to start unlocking some of the stories they had about how they used to work at that time. And with my colleagues in my research group, I came up with the idea of what I called simulation-based reenactment, wondering whether we could get more information from bringing people together to do things than just from talking to them alone, as I had with Sir Barry Jackson. And I was very fortunate at that time because in the London Science Museum, some of you may remember it, in the Wellcome Galleries, now recently dismantled to make way for their new medical galleries, there was this full-size replica of a 1980s operating theatre. It had been put up in 1983, and by the time I started working there in the mid-2000s, it hadn't changed at all. Life-size replica, as I say, of a surgical team, in this case doing open heart surgery, in a way that when it was put up was the very latest thing you could possibly imagine. Rather tentatively, I asked the Science Museum staff, particularly their deputy director, Heather Mayfield, if we could possibly do something in this space, expecting her to say no. And she said, of course, that would be fine. And so the Science Museum allowed us to take out quite a lot of this heart surgery equipment and bring in items from their reserve collection at Blythe House in Olympia to create a sense of what surgery would have been like in the early or mid-1980s. And we brought together that team of people, Harold Ellis on the left, Stanley Feldman at the top on the right, and Mary Neeland down there at the bottom, to recreate a sense of what it was like to be doing an operation in conjunction with colleagues at that time. So Professor Feldman here with the kind of anaesthetic machine that he would have been using, fairly rudimentary by current day standards, but standard for the time. A group of people working together with students, with observers, and Mary Neeland, the scrub nurse, laying out her instruments so that everything was there when she needed it. And I'm going to show you a very brief clip now of one of the pieces of film that we took. It was filmed amongst many of these others that I'm going to show you by Dr. Paul Craddock, who's here in the audience today, a filmmaker, videographer, and cultural historian. And he captured a number of episodes, which I think were most illuminating. This one, we're going to have a look at a simulated gallbladder operation. It's actually an animal gallbladder, but the principle is very similar. And here we join the surgical team. In a minute, we'll be seeing Professor Harold Ellis in the middle. We'll be seeing him in the middle, and on the left of the screen, as you look at it, you'll see Sister Neeland. And what I'd like you to do is look at the space between the two of them.
Well, I'll tell you, if you take that. Okay, I'll give a pin number. And now this is interesting. And in this case, the artery is running with it. In man, the artery is separate. Well, in mankind, men and women, the artery runs separate from it. But here you can see, I'll just have a scissor, you can see that the cystic artery is running along there.
So, if you noticed, Professor Ellis held out his hand, and then Sister Neeland, it turned out, had already got ready the instrument that she knew he was going to need. And she put it into his hand, and if you slow down the tape, you find something even more interesting, because he puts out his hand, she puts a pair of scissors into it, he withdraws his hand, and only after he's withdrawn his hand does he say, "Scissors, please, sister." So it's already happened. And so here is a group of people who worked together for many years, but who hadn't been in an operating theatre or even spent much time with one another professionally at all for over 20 years, who immediately click back into a way of collaborative working that none of them was aware of at the time. They were all astonished when they saw this video and saw for themselves the kind of wordless communication that had been taking place. So that was the sort of standard approach to removing the gallbladder.
Well, I'll tell you.
But although it seemed as if it had been like that forever, things were about to change, and they were about to change radically. So I mentioned the sort of intervening period between when I qualified as a doctor in 1977 and where we are now. and the idea that there were big technical and social developments. I think the technical ones were particularly powerful at that time because they brought about a change from thinking of the body in terms of the organs that you could see if you opened somebody up to completely different ways of visualizing human anatomy that didn't rely on dissection alone, but that used extraordinarily powerful technologies of imaging. So here's a slice through the body, and you can see that there's the liver there are the kidneys on either side. It's a longitudinal section, the backbone in the middle. You can see extraordinary amounts of detail. But it wasn't only looking at static images like this, it was procedures for carrying out interventions using radiology. So here's the kind of thing you would certainly see now and was beginning to happen then when a flexible wire is being introduced into this patient's artery, in this case in their groin, under X-ray control, and this machine round here is shining X-rays through the patient and then showing an image, and you can see that at the top right of the picture there. There's a black line which is one of these flexible wires or catheters going through a blood vessel. We can't see the blood vessel, we can't see the organs, we see shadowy shapes of bones, we see a sort of indirect picture of what's going on. But these technologies allowed a completely different approach to the inside of the body. Which brings us on to the beginnings of what eventually became called keyhole surgery. And now I want to introduce a pivotal figure who in many ways has been unjustly overlooked, I think, in terms of the history of keyhole surgery. But Mr. John Wickham, who died 2 years ago, almost to the day, at the age of 90, was really a towering figure. I'm happy to say that his widow Anne is in the audience today, and John Wickham and his colleagues were extraordinarily generous with their time and helpful to me over the last few years in building up a picture of what was actually going on at that pivotal time in the mid to late 1980s, the beginning of the 90s. So Mr. Wickham up there on the top left, this is Tony Raybould, this theatre sister he worked with for many, many years, and then a number of members of his team down here on the bottom. And when Mr. Wickham was starting his career, or for perhaps half of his career, as a urologist who specialized in stone disease, stones in the kidney, the bladder, the kind of operation he had to do involved making a large incision in somebody and then finding your way down to the kidney or the ureter and then making a hole in that and taking out the stone. And this is the sort of thing that it looked like. But ever since the beginning, Mr. Wickham told me, he'd had this vision that it shouldn't be necessary to make a huge hole to take out a tiny stone. It shouldn't be necessary to inflict more damage by the process of getting to where you wanted to go than you did for the procedure itself. There should be another way of doing things. And for a long time, he'd been trying to come up with ideas of how to improve things. And one of his pivotal contributions to me was reframing not only the technical aspects of surgery, but what it was to work with other people. At that time, it was traditional for surgeons to lead surgical teams, often in quite a hierarchical way. And John Wickham reframed that by bringing together on equal terms members of the operative team who hadn't previously been there, the scrub nurses, of course they'd been there, but an interventional radiologists and instrument manufacturers, people who were not normally to be seen in an operating theatre. So here's a glimpse of Dr. Mike Kellett, who will be joining us on the platform in a little while, interventional radiologist, and this is a clip from a panorama program at the time where he's showing a procedure that was very new at the time. He's putting in a tiny needle into somebody's side and then under X-ray control, and now he's putting in a series of tubes of increasing diameter so that he can make a hole that in the end, a channel that in the end is big enough to reach in and remove a stone, a procedure called percutaneous nephrolithotomy, taking out a stone from the kidney through the skin. And when I started talking to John Wickham and his colleagues, it turned out that that they had a lot of instruments that they'd been developing at the time. John Wickham's basement was full, he told me, of instruments that he had worked on, many of which he'd kept in his possession. I said that this was an interesting time of rapid change, and it was a time of media interest too. So here's just a very brief clip of a television interview with Mr. Wickham from the time.
Wide open and put your hands in to get the stones out. Patients can get away with a much less damaging procedure. They're less time in hospital. They can get back to work quicker. And I think if it can be done for one area of surgery, this can be easily applied to other areas of surgery. It's a question of will.
But the will depends on...
So there was John Wickham giving a vision of what might happen, not just a new technique, but how it might bring about widespread change. So that was Mr. Wickham at the time. You can see that he's, for those of you who are interested in medical technology, you can see that he's looking directly through the instrument he's using. It's an early form of laparoscope. At this stage, the technology hasn't got to the stage of being able to project it on a screen. He's looking directly down this instrument. And 20 years later, 30 years later, we invited him to come back again. And as we'd done with Professor Ellis and his team, to reenact that procedure. So we're going to join them for just a few moments at the Science Museum once again in that operating theatre where Mr. Wickham and Dr. Kellett and many other members of the team are reenacting that early stage of removing a kidney stone through a laparoscope.
It's too long. I told them to get the wires too thin.
There we go. And look again at the C-arm. Back again. Swing back. A little bit further in.
So Dr. Kellett getting the needle into the right place.
Check here, see if we've got any urine back.
Sit up here. Have you got it? Yep, there it is.
You've got it, son. Thank you.
Yep.
Well done.
Can I put the pedal to you, Polly?
Good. Here you are, Polly.
So this has all happened very quickly. I said I qualified in 1977. I was training as a surgeon in the early 1980s. This was beginning to happen in the mid-1980s. And by 1987, John Wickham wrote an editorial in the British Medical Journal, very well-known medical journal with a high circulation, in which he was talking about the new surgery. And in 1987, at the end of his article, he wrote this. He said, "It seems extraordinary that general surgeons have not yet seized upon the operative potential of the laparoscope." Prophetic words, because within just a couple of years, they most certainly had. They had definitely seized on the operative potential of the laparoscope, and people were trying all kinds of things out. Some of them worked better than others. And one of the interesting things that I came to realize as part of this project was that there are an awful lot of things at a time of change like this that people try out and they don't work. I'm thinking of them in terms of dead ends and blind alleys, things that may well have been very useful at the time, but were rapidly superseded by something even better that came on. Or they might be ideas that people tried out and they just didn't work very well, or they didn't go where the people hoped they would do. But the interesting thing about these experimental or exploratory ideas is that, as in so many fields, history is written by the victor. And these approaches get kind of written out of the documentary record. There's very little about them anywhere. Some of them weren't written up at all because things changed so quickly that they were superseded in a matter of months. Some of them were written up, but those papers have been more or less forgotten. And some of them, I think, were just swept along by the tide of events. And one of those ones that I found particularly interesting was the procedure of laparoscopic cholecystotomy. So taking out the gallbladder is called cholecystectomy. But cholecystotomy is opening up the gallbladder and taking out the stones, but then leaving the gallbladder where it was. And there was a time in about 1989, 1990, when John Wickham and a couple of his colleagues explored the idea of laparoscopic cholecystotomy because it had not yet been shown that it was safe and possible to remove the whole gallbladder through the laparoscope, through the keyhole surgery approach. Now, of course, in many ways, removing the whole gallbladder is a better thing to do, because then there's no possibility of gallstones coming back. And so over the course of a year or so, John Wickham in the middle there, with Mike Kellett, who will be joining us, and Mr. Chris Russell, a consultant hepatobiliary surgeon whose field was gallbladders, amongst other things, worked together to do, I think, perhaps 100, perhaps 120 cases of laparoscopic cholecystotomy, all highly successful. The patients did very well. But very soon after that, it was shown in France that you could take out the whole gallbladder. And this whole procedure would have disappeared from view almost completely if we hadn't had a conversation when they came together, and we reenacted that operation in the Science Museum again and documented the conversations that came out, the conversations that had been prompted by inviting these very experienced people to come together and do a procedure again. So there we are with the early days of keyhole surgery. And it seems to me that this is a process that didn't just happen then, in the late 1980s, early 1990s, leading on 5-10 years later to keyhole surgery being almost universal, and now having become almost old hat. But that process it's going on as we speak. One of the next ones to come along was robotic surgery. This is the first generation of surgical robots doing robot-assisted surgery. The Da Vinci robot involved a lot of kit, and here is the first example that was brought into the UK in 2000, when I was in the operating theatre, when Professor Lord Aradasi carried out the UK's first robot-assisted laparoscopic cholecystectomy. But I was also there 3 years ago when that Da Vinci robot became part of the Science Museum's collection and had its last outing. And there, in the course of only 17 years, something that was unimaginably advanced, that seemed like science fiction at the time, went through that stage of having become, moving from new to becoming normal, and now, although robotic surgery itself, of course, continues to develop, now becoming almost old. And I think it's interesting to think about the connection between keyhole surgery and robotic surgery, because Mr. Wickham, after he had had that pivotal effect in bringing in keyhole surgery and developing that across many branches of surgery, he too continued to innovate. He developed many approaches that underpin the current work that's going on in robotic surgery. So, Mr. Wickham over there in a conversation I had a couple of years ago. So from right to left, we've got Dr. Mike Kellett, we've got Mr. John Wickham, we've got Mr. Stuart Greengrass. There I am on the left, talking about some of these things. But I was very keen that it shouldn't just be talk, and I'm very happy to say that before he died, John Wickham not only wrote and completed, but saw the publication of An Open and Shut Case, his autobiography, in which he describes many of these events that I've just been talking to you today. It's well worth reading, it's beautifully written, and it gives a fascinating insight into the turbulent events of those times. So before we go on to the next part of the lecture, I just want to make some acknowledgements. Abigail Wood, Sally Frampton and Harriet Palfreyman are all historians who worked closely with me in documenting and making sense of the events that I've just been describing. Heather Mayfield at the time was the Deputy Director of the Science Museum, and I owe a great debt of gratitude to her personally, and also to the museum and all the many people there who made this simulation-based reenactment possible. And finally, as I mentioned a little earlier, to Dr. Paul Craddock, who's sitting in the front, who has been instrumental in helping to capture on video and film and audio many of those aspects of surgery which are impossible to put into words alone. So it's a great pleasure now to introduce my two eminent guests, Dr. Mike Kellett, interventional radiologist, Mr. Stuart Greengrass, surgical instrument designer and manufacturer. And so if we could have the screen off and the lights up, I'll invite them to come and join me on the stage. So we could have the screen up if necessary. So, gentlemen. So what I thought we could do is to explore with you both some of the things that I've been sketching with this talk. But before I do, can I just get you to say a word or two about yourselves, to introduce yourselves, Mike?
Hello, I'm a radiologist trained at Barts, and I became interested in uroradiology through John Wickham originally. And my first consultant job was at the 3 Ps, St Peter's, St Paul's and Phillips hospitals in Covent Garden. They're closed now, but they were known as lovingly as the 3 Ps, or the pissing apostles, as part of urology.
Very graphic.
My consultant job started in 1977, and I'd done my first needle nephrostomy, that's putting a tube into the kidney to drain and obstruct the kidney. I did that first in 1978. And then John Wickham said, that's a track into the kidney, let's make it bigger, let's get it stirred out. That's what we did.
So for people who are not familiar with the medical terminology, you're a radiologist, which, I mean, for a long time I thought radiologists sort of sat in basements and looked at x-rays, but it's not like that at all, is it?
It's changed amazingly over the time I was training, and after training even more so. The acceleration and change was amazing. So I started looking at chest x-rays, bones, intravenous urograms, which is kidney x-rays, and then suddenly along came ultrasound, and then came CT scanning, and then MRI scanning, and it developed so amazingly that instead of just sitting in the dark room, we're joining in now with the team.
And so you weren't just looking at things, you were actually doing things. You were steering wires and,
Yes.
and all kinds of things, and we'll come on to that in a moment. Can I just check? I think your microphone might have slipped. I'll just move that slightly over there, if that's okay. So, Stuart, yours is a different area of expertise. Tell us about yourself.
Well, I joined a company called Keyhole in 1973 as a junior engineer. It became part of the Olympus company in 1978. And I happened to be in the right place at the right time because I got involved with technology development. Initially in flexible endoscopy, so colonoscopy, duodenoscopy, developed onto interventional procedures. And then I came across John Wickham because I got interested in rigid endoscopy, primarily through laparoscopy and urology.
So rigid endoscopy is these sort of steel tubes that, as opposed to flexible moving ones, is that right?
The basic principle, a flexible endoscope generally follows the natural path of the anatomy. A rigid instrument tends to straighten the anatomy over the top of the device. And I could see a synergy between the rigid and endoscopy fields, and I could see applications for both. And some of the technologies that we were developing could be shared between the instrument uses.
But you haven't got a medical background then? Is yours an engineering background? Or?
That's right. Yeah.
Right. So you were kind of bringing together two different ways of looking at things, where you were an engineering one and a medical one.
Well, one of my enthusiasms was finding out a little bit more about how the instruments could be used. Because as you were saying earlier on, the people who were using, the physicians and surgeons who were using our equipment, could tell me what they wanted to do, but they couldn't tell me how they wanted to do it. And I developed that kind of, I suppose, skill in interpreting the demands into a specification.
Oh, so you were having to make sense of what was the medical problem they were trying to solve, and then come up with an engineering problem that solved it.
Absolutely. And in doing that, I had to understand more about what was actually going on in the operational field, if you like.
And so we're talking here about procedures that Mr. Wickham particularly would be doing with the instruments that you made.
Yes, yeah, and he was one of a small number of folk that I worked with who asked the sort of unaskable questions, the questions I'd never been asked before, and that's why I worked with John Wickham. I mean, he's a delightful personality, very easy to get on with, but he would ask the awkward question, like, why are your instruments so long? You know, why do you do endoscopic surgery like you're driving a Harley Davidson? Or why is the hole so big? Or why don't you use a zoom optical system rather? All sorts of radical questions which were immensely stimulating.
Yeah, because I guess those are the questions that make you challenge your assumptions and think things through in a different way.
Absolutely. And I had this fortunate position where I thought, well, we could use that from there, or we could swap the technologies around.
And Mike, I know one of your great skills was being able to. I mean, people used to say that you could get a needle almost anywhere under X-ray or ultrasound control or something like that.
Under both, yes.
Yes. So say a little bit about that, because for people who are not familiar with this world, you've got a very complex sort of set of organs in the body, haven't you? And yet you're looking at these images which are mostly two-dimensional, and getting a needle or something into exactly the right place.
Well, it's angle and depth orientation, and I was using that first with a C-arm image intensifier and turning that around the patient exactly the same as my head would be going around in an open operation.
Oh, I see. So you're looking from different points of view.
Appreciate how deeply the needle was going.
Mm. But then you must have been able to sort of put that together in your head as a sense of where that patient's.
It took time.
I'm sure it did.
Yes.
I'm sure it did. Because I mean, some of these organs were sort of, they'd move out of the way. I imagine the gallbladder.
Well, particularly the gallbladder was very difficult to get into. You had to stab it sharply because it was quite mobile.
Was it?
Yeah.
So how did you develop these skills? Was it just
Repeatedly.
through practice?
John kept saying, "Do another one, do another one." It was incredible working with John. It really was.
So say a little bit about working with him, because I mean, talking to you all, I get this sense of a very unusual sort of professional grouping of people with very different kinds of expertise working on equal terms to address problems collaboratively. But you were there and doing it. What was it like?
Well, he never criticised at all in what I was doing. So in that way, I could take my own time doing it. And if I was slow, he would fall asleep in the corner or whatever until I got the track in.
Yeah.
And then there were other days that happened quite often. And of course, the first case we were dilating the track over several days. And finally, he said, "Look, let's try and do one stage operation."
So when you say doing it over several days,
Well, we dilate the track, then leave a tube in the kidney, leave it for several days, start again, and dilate it again with local anaesthetic then.
oh, so because you thought you couldn't do it in one go,
Yeah, that's right.
but then you found you could do it in one go.
Exactly.
So, so whose idea was that? That was John Wickham's, was it?
Yeah.
And he just thought, let's do something radical.
Let's go, yeah.
Because it sounds, from what you were saying, as if he was quite often coming up with radical ideas.
Well, he was asking questions, challenging, and I think one of the things I found quite unusual, very unusual, was that he treated everybody the same. So everybody was an equal partner in the process of improving things. So my background in industry, the historical sort of surgical approach to industry is to call the folk like me the trade. And that's, not necessarily a terribly complimentary approach. John didn't take that approach. He accepted everybody in the process, the nursing staff, the technicians, everybody was an equal member. And so I was rather intrigued by that. So it was very easy to respond to his requests or his ideas.
And so
he's very satisfying to work with.
Was this a two-way process? I mean, you said he would ask you questions about why can't we have them smaller or Zooms or whatever. Would you perhaps come up with an idea in the bath one night and then sort of suggest it to him?
Well, I'd go back to my office and my little workshop, and I'd make them shorter, and take them back and try them with him.
Oh, so you were actually making these things yourself?
On occasions, yeah. But then things started to get a bit too clever for me, so I had to have cleverer people than me do it. But initially, a lot of these things were handmade.
And Mike, I guess you were trying out new techniques, and I mean, this was uncharted territory, I suppose.
Well, that's right. We were so lucky that patients would accept what we said. We'd said, we'll try this method, which is only a small puncture. If it fails, you'll have the open operation as normal. And so they said, yes, go ahead. Nowadays, you can't do that. Of course, you've got to operate on animals or models first.
So that must have made quite a difference to, well, I suppose it wasn't a difference in that that's how it was at the time, but it must have allowed you to explore all kinds of approaches.
Yes, exactly, yeah.
And so this idea of having people there in the operating theatre on equal terms with different perspectives, it sounds pretty radical to me, because when I was doing my surgical training, it wasn't like that in operating theatres. It was very hierarchical, and it was very clear who was the boss and who wasn't, and it was very clear that you really only spoke when you were spoken to and things. In many of the units I was in, not all of them. So this must have been pretty unusual even at the time, I imagine.
Well, my initial experiences were in gastroenterology, developing colonoscopy and gastroscopy, duodenoscopy, and the folk doing that were all young and excited and pushing the barriers back. Surgery was really quite prehistoric in this way. As you said, 40 years doing the same operation. That's unthinkable nowadays, and it was unthinkable once John Wickham came on the scene, because he was always looking for better. The best example, I think, was that we developed percutaneous nephrolithotomy with him. Very exciting technique. We were planning to make lots of money out of it, lots of new instruments. And then the extracorporeal lithotripters came along. And so we went from, a 6-inch incision to a 1-inch, or if Mike was doing it, a 1/2-inch incision, to no incision.
So this
in the
was
space of about 5 or 6 years.
This was the thing where you shine shockwaves onto people from the outside and you don't make an incision at all.
That's absolutely.
And
the patient walks in, walks out, goes back to work.
And so John was sort of seeing these new possibilities and trying them out and then moving on all the time. Were there lots of other people at that time doing that, or was he pretty unusual, do you think?
A lot of people in Germany were doing this as well, but and we exchanged many views between Germany and London.
So were you an independent person then, or were you working for a company?
Yes, a large corporation.
And they allowed you to come up with all these ideas and try them out?
They did. And then as the company grew, we started involving engineers from Japan and Germany, and it became a sort of, and even America, so it became a sort of collaborative, international working group that was working with people like John and Mike in little pockets around the world.
It must have been a very interesting time. I remember one of these enactments in the Science Museum. I was talking to John, and he pulled out one of these instruments that I think he had in his basement. And he said, "Oh yeah, no, I've completely forgotten about this thing. Interesting one, this." He said, this one won a prize, a European prize, for being the most innovative instrument for doing what it was supposed to do, which was grasping stones, I think, out of the gallbladder. And I said, "Oh yeah, very good. And what happened? Was it a success?" And he said, "Oh no, in 3 months' time it was completely obsolete. It had been swept away by new things." And so it must have been a really sort of a sort of heady time, I imagine, with all these things sort of coming up and
We were certainly trying a lot of things and discarding them, because a lot of the technology was evolving, because it started off with rigid lens systems, and then it developed into fibre optic lens systems, and then video. And these capabilities were changing very rapidly. So, we were obsoleting products simply because new technology was taking place.
Well, I think there must have been that sense of improvisation. I remember very clearly with one of the reenactments we did, talking to the two of you and John Wickham, and we were trying to put bits of stuff together, and we hadn't really done it before, and I felt embarrassed because there was all this kit and it didn't seem to quite work, and you were taping things up with stuff and sort of making things work. And I said, "Look, I'm really sorry about this because it all seems a bit sort of improvised." And you said, no, that's exactly how it was. And I got this sense that not much had changed in a way, in that you were doing things with what came to hand rather than maybe as things are done more now.
Well, I think the first percutaneous nephrolithotomies were done with a laparoscope, weren't they? Or
No,
a
the first
cystoscope.
was a
The cystoscope.
Cystoscope, yeah.
So a cystoscope is something for looking inside the bladder,
Yes.
not meant for looking inside.
Not for going through the skin. It follows a natural or a natural path follows the cystoscope.
So this was sort of thinking laterally,
Yes.
and using something that was already there for a different purpose.
He was using what was available until we were able to respond with something customized or specifically developed. John and the other pioneers had to use what was already in use.
And were you doing something similar, Mike, with your radiological techniques? Because I guess you must have been sort of inventing some of those as you went along.
Yes, we had meetings with radiologists in Europe and throughout with the States as well. So it was Euro-radiology meetings in England and Europe and in the States. And John Wickham started off an intrarenal society as well many years ago, which met every year with people all around Europe.
So this wasn't just stuff he was doing at the 3Ps.
No,
On his own. This with you, it was a sort of worldwide movement.
Open discussion, yes.
Yeah.
It wasn't just the Intrarenal Society. He also started a society called the Society of Minimally Invasive Therapy, SMIT. And he brought together on equal terms surgeons, nurses, the radiologists, engineers, industry. And that, again, was the first time I'd ever been asked to speak about technology at a medical meeting. Everything was about the procedures rather than how they were achieved.
So it was
a
pretty
very
radical
novel
for the time.
Experience.
Yeah. Pretty radical for the time.
Yes, yeah. It caused me a dilemma because he wanted me to talk about things, to be quite candid. I didn't want to talk about how we...
Oh, for commercial reasons.
How we achieved a certain performance in a product. But again, John was very irreverent. He wanted more people to know how these things were done.
So I was going to ask you both. I mentioned this idea of inviting people to reenact things from quite a long time ago, and to me that was very interesting because of seeing people who'd done stuff that I just hadn't experienced coming together to reenact them. And then listening to the conversations that prompted. But I wondered, from your point of view, you've taken part in these simulations now several times. What it was like for you, because
it brought back memories. Certainly, it did. Yes, because the questions we asked each other over the pretend body were the same old questions and the same old arguments, which were friendly arguments, but still arguments.
But they were still there after all that time.
Absolutely, yeah.
My reaction was, looking back, how on earth did we get away with it? Because we did some things that, I mean, there are many stories that I would not want to recount about how we got over problems or tackled procedures.
But I guess that
would never be permitted nowadays.
That's probably always there in the background, isn't it? When innovations are happening, or maybe not always, but
yeah, I do think. Probably for good reason, that you couldn't do anything like that nowadays. Yeah. It's far too regulated working environment.
Yeah.
So with all the developments that are going on at the moment with robot-assisted surgery, with new forms of energy, with new kinds of this or that, do you think it's a different landscape then in terms of the sort of, I don't know, the creativity, the fecundity of ideas, or do you think it's always there, but it's just slightly different?
Oh, it's so much slower now because you have to be regulated so carefully. Stuart was saying that we had some problems that we had to get over in various ways, but these were always really minor problems. What we said to the patient at the beginning was, if it fails, we'll do an open operation, and we never had to do that.
Really? But you always could have done it. You could go back to something you were familiar with doing. And I think one of the interesting things is now that being able to go back to something you're familiar with, namely open surgery,
they couldn't do it.
Is not there now because people are no longer as comfortable with open surgery, or in fact sometimes not comfortable with open surgery at all for those procedures.
Quite.
So it does make you think, doesn't it? Makes you wonder about which of these procedures that go from being new to being normal to being old and then being discarded, what we may be losing as well as gaining in that process? I don't know. It's an open question. And actually, I think it's probably a good time for us to stop this conversation and see if there are questions that we might invite from the audience. So could we have the lights up, do you think? So, would anybody like to ask any of us a question or make an observation, raise a point? We've got a gentleman over here. Angela, have you got the microphone there? Excellent. Gentleman over here in the second row.
Hello, can you hear me?
Yes.
Yeah. So I wanted to know, was the driving force behind this surgeons wanting to use new techniques, or at what point did the hospital authorities start realizing that the recovery of patients was much shorter and therefore there was a really good economic reason for pushing it forward?
They were slow, but they did realize that after some time. But it was surgeons pushing the idea forwards, particularly one surgeon.
Can I give you my perspective on that? As I said, I had a role in developing flexible endoscopy as well as laparoscopic surgery and so on. And I had the chief executive of a very large London hospital group say to me, the problem with your equipment is it means we can treat more patients. Which I really didn't understand. And so, being rather simple, he explained it that more patients meant more expenditure. And they at that time, it wasn't looked upon. What we were doing was, by the hospital authorities, considered a bad thing, not a good thing.
So you were coming up against pressures of various kinds.
Yes, I mean, I don't know how it works in hospitals nowadays, but treating more patients was not considered good because it meant more uncontrolled expenditure.
And I mean, that wasn't the only pressure, was it? Because I know that John Wickham told me, and maybe you experienced this too, that there was quite a lot of resistance in the profession, particularly that operation I mentioned earlier, the laparoscopic cholecystotomy, when John Wickham was taking out gallstones, and people said, well, what on earth is a urologist doing taking out gallstones?
Yeah.
And there were kind of territorial issues, weren't there?
Oh, very loud ones, yes.
Which I guess goes with the territory of innovation anyway, but particularly maybe these radically different ways of thinking about medical care that sort of go outside orthodox disciplinary boundaries.
I mean, that was the real example of lateral thinking that John had. Lateral thinking to use, if we can puncture a kidney, we can puncture a gallbladder. And so...
So he wasn't thinking, I'm a urologist, I deal with kidneys.
No,
he was thinking about what can we do with the needle.
Exactly, yeah.
I think despite what I said about the chief executive of a big London hospital group, I think generally the environment was much more positive. I had a lot to do with America, and I mean, the definition of interventional radiology, which is what Mike was the intervention of the radiologist on the surgeon's pocketbook, wasn't it? They really, surgeons were strongly opposed, not because of medical or ethical reasons, but because of money. And that was never an issue with surgeons or urologists, radiologists in this country. No. We were blessed with a health service that didn't worry about who earned what.
But I do remember you telling me, I think it was you telling me that you had quite radical ideas for the whole clinical pathway, not just procedures. Say a little bit about that, because that seemed to me to be decades ahead of its time.
Well, for reasons I can't remember, I started looking at what happened to the patient before these procedures were done and what happened to them afterwards, because my life's focus had always been on the point of the procedure. And when we started analysing this and video recording it and looking at, we had some ergonomists look at the movements of patients and so on. But I also got interested in patient information, what patients were told. And were they told anything? Were they told things that raised their anxiety level or reduced them? And so we got involved with producing patient information leaflets to try and reassure patients about what was going to happen to them. And then we started looking at what happened to them, the surrounding area, the logistics of the procedural field, and we were staggered when we stood back at just how much clutter there was in a surgical procedure room. Again, this was another thing John really liked. He liked minimal amount of clutter. He noticed in that film he didn't wear a hat or a mask. Very, very unusual, unprecedented in my experience amongst, for surgical procedures. He didn't think it was necessary. So anything that wasn't necessary was discarded. And we found that very interesting. And if you look at procedural rooms now for laparoscopic surgery with boom arms and television and so on, there is actually a minimal amount of equipment. Everything you don't need is pushed away. And that was what drove that development. And then, because the next stage was what happened to the patient after, and how they were recovered, how they were moved physically, and where they were put, what the environment was like. Was it stark and white and clinical and scary and stainless steel and lamps, or was it soft, gentle sort of recovery process? And indeed, there's a facility in London at this moment which facilitates some of those ideas of making it as nice a process as you possibly.
So it wasn't just laparoscopic instruments and light sources, it was about systems and things.
That's what it became, yes.
Fascinating. Thank you. Another question? Anybody? There's one over there, halfway up on the left.
Could you raise your hand, please?
First, thank you for a very illuminating discussion. It seems to me that you're almost moving the operating theatre inside the body. And if you're doing that and controlling it remotely, you can do it from almost anywhere. And I wonder whether the trend is away from having people in a room performing a procedure on a patient to having that room moved into the body with all the bits and pieces that go with it, and then extracting it again afterwards.
Well, that's been done in some ways in operating in, as they say, on the front line, when the medical team want an operation done on the front line. That's done often by
in military settings and things.
Yes.
Yes. And I mean, I suppose it goes back to, in a way, to what you were saying about designing a whole system, rather than just bits of a system, rather than this new instrument or that new. You were talking about thinking about the whole thing from beginning to end, and what you're talking about is sort of maybe miniaturizing or focusing everything you need on the inside of the patient's body. I think, well, the next one of my Gresham lectures, but one, is going to be looking at exactly that. It's going to be looking at where the new approaches in robot-assisted surgery and things might be leading us, and whether we want those things to happen or whether we don't. And what are some of the issues that these new technologies raise? Because I think it's not just as simple as thinking what is possible, but we have to think more widely. What is it that we want, and what should we be doing? And on that note, we've pretty much run out of time. So can I say a huge thank you to Mike Kellett and to Stuart Greengrass for such a very interesting conversation.